Today on the show, we're joined by Dr. Quentin Van Meter, a pediatric endocrinologist who has spent decades watching the field he loves get overtaken by gender ideology. From his early training at Johns Hopkins, where he first encountered John Money, a controversial figure, to treating children whose lives were derailed by sexual identity confusion, Dr. Van Meter has witnessed the fallout firsthand. He breaks down why puberty blockers are not a harmless pause button, but the first step in a medical pathway that disrupts brain development, weakens bone density, and can jeopardize fertility for life. He also lays out the irreversible damage cross-sex hormones inflict on the body. We dig into the disturbing origins of modern gender ideology, from Money's unethical experiments on children to how those ideas quietly took over American medicine, repackaged and unchallenged. Dr. Van Meter shares patient stories, ethical warnings, and what he believes parents and clinicians urgently need to know before making irreversible decisions for children. If you've ever wondered how unethical, experimental ideas became mainstream medicine and what it takes for the truth to finally break through, this episode is essential listening. Before we begin, a quick note. This episode includes discussion of medical trauma, unethical human experiments, child sexual abuse, and irreversible medical interventions that may be difficult for some listeners. Please use discretion and take care while listening. Welcome to the Bioethics Babe podcast, where we examine the tough questions in human flourishing in light of science, faith, and culture. I'm your host, Arina Grosso-Agnew. Now let's dive in. Today's guest is Dr. Quentin Van Meter, a pediatric endocrinologist with more than 4 decades of clinical and leadership experience. Dr. Van Meter began his career at the College of William and Mary, went on to earn his medical degree from the Medical College of Virginia, and trained in pediatrics through the Naval Medical Corps. He later completed his pediatric endocrinology fellowship at Johns Hopkins Hospital, one of the most influential centers in his field. After serving 20 years in the U.S. Navy, including leading residency training programs and working as a staff pediatric endocrinologist, he moved to the Atlanta area, where he built a full-time endocrine practice. His clinical research spans growth hormone, insulin therapies, and GnRH agonists for precocious puberty. A seasoned clinician and former president of the American College of Pediatricians, Dr. Van Meter brings a deep and hard-earned perspective to today's discussion about puberty blockers, cross-sex hormones, and the history of gender ideology. Welcome, Dr. Van Meter.
Glad to be here, Irina. Thanks so much for the opportunity.
Thank you. So you've spent decades in pediatric endocrinology. What first drew you to this field?
It's very interesting. Back in the medical school days, my third year of medical school, I had decided definitely I was going to deal with pediatric patients in the future. Having interacted with adult patients, I decided, kids want to be well, kids love to be well, adults love to be sick. And I just said, I've got to go into something where everybody has some optimism about being well and wants to be well. And I liked kids growing up. And so one of my mentors was a very, very bright young man from Philadelphia. And he had trained as a geneticist, which was back in the day a very narrow field, because what we had was just whole chromosomes to deal with and not a lot of other things. He had no background in endocrinology, but had a lot of interest in metabolism. And he ran specialty clinics, and he was really well known among the staff as being a very aggressive, high expectation kind of guy. So I went into my month rotation with him a little bit scared, but thinking that if whatever I can learn from this guy, I want to prove my mettle as a medical student. And the month was absolutely spectacular. He really never trained as a pediatric endocrinologist, but he knew an incredible amount about it, and he could teach it well. And he just piqued my interest in that. I'm not an algorithm kind of guy. I can't memorize very well, but if there's logic to it, and endocrinology is all about balance. If one thing goes up, the other thing goes down. If one thing goes down, the other thing goes up. makes a lot of sense to somebody like me who thinks like I do. And I put that together along with my love of general pediatrics and came up with the idea that I wanted to be a pediatric endocrinologist someday.
Wow. So, yes, endocrinologist is all about balance, hormones, growth, metabolism, as you mentioned, and about helping the body do what it's designed to do. What do hormones teach us, not just about the body, but about being human? And how has that shaped your understanding of human development and sexual identity?
Well, I marvel at the complexity of the human body, and every human being is a miracle. It's just there is so much that can go wrong, and there are things that go wrong in major ways and in minor ways. And I think it teaches you about the order of the human body as an image of God. With imperfections that can be helped. I think making those imperfections affect the body less adversely over time is the role of a physician. So we are again flawed as human beings. Things are so complex down to the molecular level; it is beyond comprehension. And we are only now unwrapping. Through the use of the human genome analysis, what happens within chromosomes, within the genetic messaging that comes out of each cell and what its role is in the body. Molecular genetics is the place where diseases are going to be solved, and God presented, I think, that to us and opened that door through very smart people, and it's going to allow us to. Within the bounds of ethics and morals and our religious teaching, do a lot of good to humanity over the long run.
Mhm. So you trained at Johns Hopkins, which is interesting given that that is the same place where early gender ideology research took shape. What was the environment back then?
Johns Hopkins was a mecca in the sense that when you walked into the buildings, you felt the ghosts of the giants of medicine from the late 19th century, moving forward into the 20th century. The names of the buildings were the names of physicians who were the first at many, many things in surgery and medicine. It was a place of honor. Everything seemed to be on a scale where you didn't want to disappoint anybody. And very interestingly, in the very center rotunda of the building, which is sort of the hallmark of the medical campus, was a giant statue of Christ, and yet there was a very secular nature about the people who practiced and worked there and who taught there. There was always that reminder as you went through and entered the building that Christ was there, standing with his arms open, and it was pretty special.
Wow, that's not something I knew. So thanks for sharing that
Yeah.
tidbit about Johns Hopkins. Was there a turning point in your career, maybe a patient experience or something like that, that formed how you viewed sexual identity disorder and endocrinology?
There was one particular patient, was a little baby that came down for a consultation from Buffalo. It was a little boy, and he was sent to us by a fairly seasoned endocrinologist who had actually trained at Hopkins herself many years before. Well, not many years before, but before my time. And the issue was that this little boy had a very, very tiny genitalia. His penis was almost not present on the exam. You had a difficult time finding it. Was a chubby little guy at age 6 months. The testicles were not palpable in what was sort of looked like what the scrotum was supposed to be. And our job was to figure out what was going on with this child. Now, in the background, all this time was Dr. John Money, who was a clinical psychologist who found his way to Hopkins in the early 50s. And in the early 50s was when pediatric endocrinology actually sort of began as a specialty. Dr. Lawson Wilkins was sort of assigned. He was a pediatrician. He was assigned by the chairman of the department. Wilkins, you're going to do endocrinology. So and so, you're going to do calcium metabolism. So and so, you're going to do cardiology. This is how the division started. And so Lawson Wilkins was the guy, and he was a very bright man, and hormone concepts were just being developed. And he and his faculty actually outlined the way that the steroid hormones essentially develop the genitalia in utero, and how when things go wrong, why things go wrong, what babies look like when that happens. And so Money was one of three individuals at the time who were sort of responsible for the leaders of the sexual revolution, Kinsey being the other and Harry Benjamin being the third. And they had decided that gender identity was a concept. That is, if however a person was born, by the time they became 2 or 3, they had a sense of whether or not they were a boy or a girl. And he thought it would be really interesting to play with that and say, if you had a baby that had an ambiguity of genitalia where you sort of thought it was a boy or thought it was a girl but weren't sure, could we play with that child and direct that child into an identity that might not be congruent with the biologic sex? And that's why he was there. He focused on kids that had early puberty. He focused on kids that had late puberty. He focused on kids that had abnormalities that made their genitalia grow excessively on the basis of hormones that were present that shouldn't have been present. And, he was all about, figuring out what he could do to manipulate or understand where these kids were in terms of their spectrum and their sexuality and their sexual orientation and how they would live out their lives. So he hooked on to Lawson Wilkins right away and sort of followed him around. And in a biography that was written, he claimed that he was essentially a pediatric endocrinologist in his own right, even though he'd never gone to medical school, had no medical training, was a psychologist. And so he presented himself in cases. In this particular case, there was an evaluation that we felt didn't need to be done because it was pretty cut and dry. We knew what this little baby likely had. And we didn't think there was any reason why John Money should step in and evaluate the family as to how they felt about their boy, whether or not they wanted the boy to live as a boy or live as a girl because of the very tiny genitalia. We didn't consult him on this one. And he happened to be out of town doing some conference, I think, in Europe. We saw this baby, and my faculty mentor and I laid out a plan of attack, if you will, of evaluation that was very logical, very much in the standard of care. And it involved finding out whether or not, A, this baby had the ability to make testosterone, and if so, would his tissue respond to that and allow the genitalia to grow? I mean, it's to me one of those very logical things that endocrinology is all about. So we kept the child in the hospital for a week, and we did a stimulation with human chorionic gonadotropin, which is it stimulates the gonads, the ovary and the testicle, to produce their hormones. And we did a fairly intensive treatment for the first week and sent him home for 6 weeks on twice weekly injections of the same medication. And we fully expected that we would see the baby come back with a very much larger penis and testicles that could be palpated in the scrotum. And the answer to the question would be, this is a boy, has always been a boy, will function as a boy, everything's going to be fine. After we did our evaluation and discharged the baby, before the baby left the hospital, John Money happened to have returned, heard about this kid through the grapevine, grabbed the mother and said, the endocrinologists don't know what they're talking about. There's no possibility that you're going to be able to raise this child as a girl. His genitalia are non-functional, will not respond. I want you to go home, rename your baby as a girl, dress your baby as a girl, tell the family that there was a mistake in the delivery room, that this was they had a girl child instead. We didn't know that. The baby came back 6 weeks later in a pink dress with an eyelet bonnet and the name of Tabitha. My attending and I kind of looked, and Grandma was in tow this time, and we undressed the baby, and there was a very healthy, normal penis, and scrotum had palpable testes. We had our answer. Yes, the only thing that was missing was the signal from the brain that normally would have brought the genitalia to normal size in the third trimester, the signal had not happened. And that is what we call hypogonadotrophic hypogonadism. It was missing GnRH, which is the signaling hormone from the hypothalamus. That can be hormonally stimulated later on for fertility. You can replace the testosterone. Everything can work perfectly well for this child. At that point in time, we essentially made it a rule that John Money was not to see any more patients in the division without the head of the department giving him specific permission. And that one really sort of put in my mind, this is a man who was unscrupulous, experiments on children, should not continue to have any business at having anything to do with patients. That was my awakening point.
Wow, that's very profound. And whatever happened to this baby? Do you know if the baby was raised as a girl or as a
No,
boy?
baby was raised as a boy. Grandma was overjoyed. She said, I
Okay.
thought something was going on. So,
Oh, thank
out of the
God.
jaws of the devil, this child
Yeah.
was rescued, and then followed up in Buffalo. We did not see that child again. And
Okay.
actually, it was right at the end of my fellowship here, so that child may have come back after I left. I didn't try to find out.
Yes. Well, thank you for giving us that preview of John Money. We're going to have a whole section just on John Money and the beginnings of gender ideology. But that story is very powerful, and I think is going to resonate with our listeners. So you mentioned that the field of pediatric endocrinology has changed over time. What kinds of cases are you seeing today that you didn't see 20 years ago?
Well, the whole concept of the transgender patient is a new thing in pediatrics. After I finished my fellowship and after at the end of my 20-year naval career, we moved to Atlanta, and I was practicing both general pediatrics, which I loved, and endocrinology together. And a family came in from California. It was a military family, and the dad had been stationed for a short time in Atlanta, working with the college students in recruiting. And he brought his family of 5 children along with him, and one of them was a 13-year-old boy who had expressed several years earlier the fact that he thought he was born in the wrong body. They consulted a psychiatrist in Los Angeles, and that psychiatrist decided that the family should raise this child as a girl when they moved to a new duty station, and they were with a whole new set of social friends and whatnot, and this child could be introduced to his new environment as a girl. They wanted me to provide estrogen. Puberty blockers were just beginning to be used, but they were not FDA approved yet. And so that wasn't, he was already well into puberty. And so I got on the phone with my former department chairman, with some of the fellows that had gone off from coast to coast. And I had garnered information and ways to contact a lot of the endocrinologists who were my mentors and who were other people's mentors across the country. And I said, what do I do? I've never seen this before. Is this something that you can help me walk through? Because I don't know about dosing. I don't know if this is real. Is this the right thing to do? And everyone just said, we don't know. This is not something that we have ever seen. Money at Hopkins had done things with adults, and yes, they had done things in infants and toddlers that were manipulative hormonally and surgically, but this was a de novo healthy boy coming in mid-adolescence. And so they said, well, I guess you could start him on estrogen, and this would be maybe some dosing to do that. And what you need to do is to get your medical practice attorney to write an informed consent that basically protects you from any damages that might happen from this experiment. And so I did that, and the parents consented. And I started him on estrogen. Well, within 5 months, the family moved out of the Atlanta area up to Washington, D.C. I referred them to the pediatric endocrinologist at Walter Reed, the regional place where they could get medical care within the military system, and the family never showed up. So I don't know what happened to that child, but that was 1993. nobody in the pediatric endocrine world knew what to do or what to advise. So I mean, it was a vast, empty, circumstance in terms of knowledge and where to go. Just 2006, 2007, all of a sudden we're opening clinics across the country to do puberty blocking and cross-sex hormones as a matter of routine in these kids. So we went in a progression that defies science, defies genetics, defies anything. That it basically says something's going on that's not biologically based; it's socially based, and that's the different world we're in at this point in time, where we have 60 plus centers, some of which are closed now. But we have Planned Parenthood and some online services that are providing puberty blockers and cross-sex hormones, just with some interviews, cursory interviews. So it's a very different landscape today.
Do you think that money is driving the opening of these clinics? What's driving this?
Well, pediatric endocrinology as a subspecialty has been chronically known as a loss leader in academic centers, because the big cost of taking care of endocrine patients has to do with mostly with patients with type 1 diabetes, who need intensive follow-up and technology and whatnot. And that's our passion, is healing. And we put ourselves all into that and do things. Just we don't sit there and think, how much is this going to cost? We say it needs to be done because this is the right thing to do, ethically and morally, to heal the patient or to help them through their disease state. So the endocrine divisions have been really stepchildren in academia, until all of a sudden here is a coded diagnosis and a coded treatment intervention that isn't covered by insurance often, and then therefore is a cash cow. You bring it in, you're all of a sudden the endocrine divisions are running in the black, and then some. And so it's kind of nice to have something like that. It's almost like plastic surgery, which is cosmetic and not covered by insurance. You have income coming in, cash on the barrelhead, no denials from insurance. Everything the parents write the check, and off you go. The puberty blockers themselves are outrageously expensive. On an average, treating for a year is about $60,000.
Wow.
The hormone replacements are minimal. Testosterone and estrogen cost next to nothing compared to that. Maybe, a couple $100 a year. And so there's not money making in the hormone replacement, but there is money making in the puberty blockers. And then the whole can of worms, which is, I know you're going to be talking to another individual who's a plastic surgeon. That is a giant moneymaker for both the surgeon and the medical facility. So I can't help but believe that there are incentives that are monetary. But overarching that is this bizarre sense of, guilting into doing things to patients because it's an inherent defect that needs to be treated and cured, quote unquote, when indeed we know that's not the case.
So let me just get this straight. How much does insurance cover for puberty blockers or cross-sex hormones, or is it mostly paid by individuals?
It Depending on how it's coded, it's ended up, if it's like a gender identity transgender issue, it's going to be coded as such, and it's not going to be covered. But if you cleverly put in deficiency of hormones and we're replacing them, and insurance tends to cover that. So it's all about people, kind of getting around the system.
Hmm. So many doctors feel pressure from institutions or professional organizations to quote unquote affirm sexual identity disorder rather than to question it. What kinds of pressures have you experienced and seen in your field?
Well, I talked to my colleagues, many whom I've known who are my age, and then some that are younger than I, about what they're doing at their own individual institutions. And they'll say to me, "I don't do it. We have a clinic where that's done. So I just don't send. I don't. The patients go there. I have nothing to do with them." And when I say, "Well, do you actually believe that this is an appropriate thing to do?" They say, I can't really express my opinion because I will be removed from faculty, or my research money will dry up, or I will be labeled such that my articles won't be accepted for publication. So they're under an intense amount of pressure. I had a wonderful opportunity to meet with Dr. Paul McHugh face to face, and he was the chairman emeritus of the psychiatry department at Johns Hopkins, and he was there when John Money was doing his stuff, and he helped John Money kind of quit doing all that stuff. And he said, this is sad, but lawsuits are going to bring this to its knees eventually. I was so excited having met him. He's such a giant, and such a beautifully, profoundly faithful, religious person. Ethics to the bone. Just being in his presence, you just know this is a good person. He sort of glows, okay, with goodness. And I came back to the pediatric endocrine meeting in town, which was the other reason I was in town there. And I ran up to my mentor and I said, Peter, I just had this most amazing talk with Paul McHugh. We've got to do something about this transgender stuff. And he grabbed my hands and he said, shh, don't say anything. People are going to listen and hear what you're talking about. And you're going to be in trouble. And I just looked at him like, wait a minute, I've respected you as a mentor forever and ever. And you're just bypassing this and saying, this is something we don't talk about, we don't challenge, because it will get you in trouble. And that just blew me out of the water.
Yeah, and I think there's a lot of fear and, as you said, loss of jobs, loss of titles, loss of research for standing up and fighting this. Can you tell us a little bit more about Paul McHugh and his research and his everything that he's done for the movement?
Well, in the background, first of all, prior to this being on the front burner, he was essentially the world's respected expert on human sexuality and in terms of the psychiatric and mental health side. Published extensively, textbooks, edited, written. You would think that you would be dealing with somebody who was sort of arrogant and self-important. Okay, he was 180 out from that. He's about 5'6". Excuse me, yeah, 5'6", and it's white hair, soft-spoken, gentle. He basically battles for the good of his patients. And his prior big battle was repressed memories, which was the big thing in the 1980s, where kids were, again, wagging their parents by the tail and flipping them around, saying that they had been sexually abused by relatives or by the parents, intimately detailed stories of stuff, all of which was fabricated. And the kid got to run the parents essentially many times into jail, caused divorces, caused family dissolutions as they were going through their adolescence, suddenly remembering things that they were sure happened, which actually had never happened. Reported through schools. Schools were in the background, helping the kids get to attorneys, to get the parents to have their children taken away, all for just made up, fabricated stuff. And he saw that, and it made his blood boil, but in a very effective way. He brought parent groups together and he gathered lawsuits. And he said, we took the giant down. And that whole diagnosis essentially may still be codable or maybe mentioned in the DSM category books, but it was totally, the air was let out of the tires and it just disappeared off the radar screen very rapidly, almost as rapidly as it came forward. And so this transgender thing was his new project. And he wrote an extensive piece, and he said, I'm going to do this, but he said, here I am, a practicing faithful Catholic, and I don't want this to be viewed as a document of the church, or he said, I can't help that it influences my thoughts and the way I practice medicine and view the world, but I'm going to have it critically reviewed by a bioethicist, statistician, who is himself gay, and I want him to go in there and I want him to just tear out anything that is not based on science. And he found a colleague to do that. And he said to that colleague, would you mind being the first author? Because if you're there in front, when they try to attack us on the basis, oh, there's just some right-wing Catholic idiot, who's anti this, anti that, and bigoted, they will see your name there, and you are very well respected in the field. And so, would you do that? And he agreed to do that, and it was published. And immediately, within a day of publication, it was trashed by an innumerable number of people by online surveys. People who couldn't have possibly read it because it would have taken them a week and a half with intense focus to do that. But he just, quietly just did this. And, he is working on this project to this day in the background. Just one of the most a man I respect most in the world in the field.
Well, thanks for sharing some of your stories, your personal stories with him. Beyond sexual identity topics, what are some of the most rewarding aspects of your work in pediatric endocrinology? And what's a case that has reminded you why you went into medicine to begin with?
I will tell you that the most rewarding things that I do in this current diabetes is so intense and so overwhelming. The improvement in technology and the ability to get these kids to be in the best possible shape they can is extremely rewarding when it works, when the child accepts it and the family accepts it. But even more rewarding than that now are the kids who come in with obesity. Obesity is a stepchild of the endocrine world, has been for a long time. And these kids are so downtrodden and so self-loathing. Their parents have been through what the children are going through many times because of genetics, not because of bad social habits. And I spend at least an hour and a half just opening their eyes to the fact that they are good people who were biologically designed to collect their energy, their food energy, and store every bit of it and not waste a dime. And I get them over the hump of self-guilt, and I talk to the child, and as I'm talking to the child, if either of the parents have experienced it, they begin weeping.
Mm.
And it's hard for me not to join them. Because the burden is lifted off their shoulders, and I watch them transform their own views of themselves. And then we lay out a pathway to say, there is a way where, with a lot of work for every day of the rest of your life, you can reach a goal of losing body fat, not losing weight, but losing body fat and replacing it with healthy muscle. And you will knock the world over if you do this. And by the end of the meeting, we're all hugging each other. And when they come back and they are successful, which many, many, many of them are, we just enjoy the time together. And that's probably the most rewarding thing. If I would miss anything I couldn't do, it would be taking care of those kids and their families.
Beautiful. What's the hardest part of standing up against the current medical narrative around sexual identity?
There's a lot of negative feedback from every angle. My faculty positions at the two medical schools in Atlanta has been taken away from me. Now it's non-remunerative, so it wasn't that it basically made it a hardship for me. But I no longer am allowed to teach residents and medical students in my office setting. And the office setting opens their eyes. When I've done this, I've turned pediatric residents into pediatric endocrine, champions, because they see what we do and they want to do the same thing. And they realize that, necessarily working in a laboratory in academia might have been a dream, but this is they watch what we do and they feel like, this is what I want to do when I grow up. Okay. And now I don't have the opportunity to have those kids come in and take part in my office. So that's for me one of the most personal things that it's kind of a sad thing. The other stuff is all purely anger, and I pray that I don't hold these people as bad people that should be punished, but I pray for them to kind of have a conversion to reality, and it's an application of my faith to say, look, I've known who you are, and I actually have personally known you for 30 or 40 years, and I have a different viewpoint, and I would like to have this dialogue with you. I'd love to sit down let you listen to me, let me listen to you, and see if there's a way we can solve this problem that doesn't harm the kids. And so, but I've had a letter sent to my office with white powder in it. We had to evacuate all 8 stories of the building into the rainy day, while at Homeland Security, FBI, and police came to the building to evaluate. It turned out that it was just flour, the white powder, but it was a very hateful letter. I've received easily 60 or 70 profoundly god awful emails when we had a data breach at the American College of Pediatricians, and they had access to my email. Saying things that just would curdle your blood. Those things they don't damage me, they don't discourage me, but it's there's a target on my back, and I realize that. I have been removed from a speakers bureau from one of the pharmaceutical companies, having nothing to do with growth, the issue of transgender or puberty itself, just because somebody decided that I was unsuitable. I've had lectures that were scheduled that were canceled at the last minute because they wouldn't have me be a speaker. So it's just, those kinds of things happen. But I view if I'm doing a greater good and there has to be some sacrifice, it's a small sacrifice. I think what happened to Charlie Kirk those months ago, what would happen if I were up on a stage speaking on this issue from the scientific standpoint, and someone decided to take my life? I'd say, well, it was my time. There we go. I'm going to continue to do what I need to do.
Well, it just shows that you're effective, and because you're a threat, right, to the current ideology. So I would wear it as a badge of honor, and of course we'll pray for your protection as well. But obviously, you've been asked to testify countless times in front of various legislatures, state and federally too, against what's going on with all of this. So um, I want to now go into puberty blockers. Let's talk a little bit about puberty blockers specifically. Then we'll talk about cross-sex hormones, just so that our audience understands what's involved with all of this. You said that these drugs, puberty blockers, were never intended for treating sexual identity disorder. What were they originally designed for, and why do you think using them in the current way is risky?
The original design, the puberty blockers are so spectacular because I'm in love with endocrinology, so it floats my boat. The puberty blockers very selectively tell the pituitary gland to not release the hormones that tell the gonads what to do. The pituitary gland is a multi-specialty gland. It's kind of, I feel like a bag of gravel where every pebble in there does a different thing. It tells the body to secrete cortisol, to make the thyroid gland work more efficiently. It helps you balance your water intake and output. It tells you when to go into puberty. It helps you grow. It secretes growth hormone. All those things are individual, sort of like with a marionette above it in the hypothalamus, the control area right above the pituitary gland. It's sort of pulling the strings, telling the gland what to do, when to secrete it, how much to do, when to draw back. And so the puberty blockers very selectively are so profoundly strong. They took the indigenous natural hormone that the hypothalamus did to signal and made it 1,000-fold more powerful. So it's given into the body, and the pituitary gland can't tolerate that degree of stimulation. Right. It's the receptors for that hormone, plug their ears and say, no, the noise is too loud. I'm gonna flip the circuit breaker. And so it's a reversible in terms of letting the pituitary signal those hormones down to the ovaries and testicles. But as long as that noise is there, the circuit breaker is overloaded and it shuts down very selectively. Everything else in the pituitary gland works just as if nothing else were going on. And this was designed initially for adults who had hormone-dependent tumors, prostate cancer in males and ovarian and uterine cancer in females. And they figured out very quickly how to shut down that signaling so that there wouldn't be any escape, and the organ wouldn't produce hormones that would promote the cancer growth. it dawned on the pediatric endocrinologist that here we had been using of all things, Depo-Provera, which is a long-acting progesterone currently used willy-nilly for birth control. We used to use that in children to shut down the signaling to their gonads when they were starting puberty at a very specific, very early age. Girls who were 3, 4, 5, or 6, boys in that same age range who, for whatever reason, the pituitary started getting the signals from the brain, time to start puberty. And that was a problem because the kids would end up profoundly short and also having to deal with the hormones that were being developed at a time when they're socially and their brains were not ready for them. So you started using those hormones, the puberty blockers, just in children, FDA approved for use in a very strict range of age and circumstances to temporarily cut the signals to the gonads so that the kids could grow up, get to the right age, and then we would take that signaling, that hormone blocking away and allow them to ease back into puberty at a time when their body would have physiologically been appropriate. Their brain, would then be able to have the hormones of puberty, their body the same. They would join their peers at the right age. There would be a better growth outcome as a result of that. We did learn as we used these in the long run that there were some side effects, that there were, if somebody had anxiety to begin with, that these puberty blockers could make that anxiety worse. So there were things that we learned that, hey, you just got to be careful and explain to the parents, and when they're signing a consent, this is what might happen. If it does, we will be able to discontinue treatment and everything will kind of settle back down. So these got FDA approved, which means you didn't have to have consent anymore. They became a standard of care to treat kids with precocious puberty. Interestingly, when you block puberty in a kid, particularly in girls, because it's a ratio of precocious puberty in girls to boys is about 5-1. When you're getting ready to take them off, the fathers would typically say, "Oh, could you just please leave my daughter on this until she's 18?" Then we don't have to worry about puberty. Life will be much easier. And of course, we chuckle about that and say, no, this is a very necessary part of human physiology for the body to mature. The brain, the bones, organs throughout the body need the hormones of puberty, and puberty is a process that probably did cause everybody who goes through it some degree of pain and agony, but no, it's necessary. It's a suffering through which we go to become from being an infertile child to being a fertile adult. And so that's where the puberty blockers have been used, where I have used them regularly. I have been involved in clinical studies of how to improve the delivery and the length of action of the medications. Currently in a study looking at an injection that can be given once a year. And so it's a big interest for me. I understand the physiology. I love it. It's what endocrinology is all about, is helping things get back to essentially a more effective norm.
Mm-hmm. So it sounds like there are very legitimate uses of puberty blockers. And I just want to remind the listeners that obviously medicine is about healing when something is not working as it should, whereas how puberty blockers are used with sexual identity disorder is to stop a perfectly healthy, functioning organ from doing what it should do and from your hormones doing what they should do. So there is a legitimate use that heals the body, that helps the body, and there's an illegitimate use that actually harms the body. So talking about the harms of using it for sexual identity disorder, some people will say that it just pauses development, that it's fully reversible, and that it gives kids time to decide, think before making bigger decisions. And you've said that this is misleading. Why? What's being interrupted at the hormonal and developmental level when this is happening?
So, as I mentioned, when puberty happens too early, stopping it and then letting it kind of come back into blossom at the right physiologic age has not been associated with issues of that can't be essentially restored. We're not dealing with bone density yet. where fertility is not an issue, has not been an issue for the kids that were treated and then let to come back at the right age. The emotional stuff, that's is something that we are paying more attention to. But beyond that, everything else that happens in the childhood essentially is reversible. And the proponents of doing this during adolescence just borrow the experience from kids and say, you see, it's all reversible. Well, the problem is it's the timing of the body, where the body is expecting puberty, when it needs puberty to survive into adulthood. It's not there. You've taken it away. So the concept of it being just a pause, that would suggest that the child was in significant therapy in terms of all the emotional problems that were discovered, and just needed to not have to deal with the hormones of puberty for a little bit longer, for a year or two or three, so that the counseling and all could get this child to essentially accept themselves. Okay, that's the pause button. Okay, the problem is that within 6 months of starting the puberty blockers, the kids are on cross-sex hormones because they want the puberty that they weren't designed for, and they don't want to wait for that. Delay in puberty we see over and over and over again in healthy boys, and it just tends to ruin their lives as they see them growing up. Everybody else is getting bigger, stronger, and horny, and I'm small, tiny, and I don't know what those guys are talking about. So I'm outside the sphere of where I want to be with my friends because I'm not in puberty at the right time. It hurts not to be in puberty. So the kids who pause want to be in puberty, but just the wrong puberty. So they don't.
Mhm.
The pause is a joke. It's basically just the first button on the conveyor belt. The next one is 6 months later. You're begging for the hormones that will make your body look like it's the opposite sex.
Mhm.
So it's a myth, okay? And I love Dr. Michelle Cretella's quote that says, puberty is not a disease. So why are we treating it as such and blocking it? And so it is not reverse. We know it's not reversible in terms of bone density. We know it's not reversible in terms of brain development. Recent research has uncovered the fact that dementia occurs when the gonadotropin releasing hormone signaling system is either doesn't develop or is prematurely interrupted. So we know the brain is very dependent on the hormones of puberty and the actions of the puberty blockers. So those two alone, and then of course, when you block puberty, the gonads don't develop. So there is essentially an infertility for the moment, but that's often followed by removal of the gonads. We have no long-term data to say that we're going to recover fertility in these people. So it's an ongoing. It's what John Money used to do. I have an idea. Let's do this and see what happens down the road. Okay. And the people who have done this to themselves and regretted it and come back to detransition explain how awful it was, how they felt about what they'd done to themselves, because they missed things that their body needed and they can't be recovered.
Mm-hmm. So let me just get a clarification here. When it's done for legitimate purposes with younger children, things could be fully reversed. But when it's done later, when puberty already starts with adolescence, that's when you have this host of risks. Is that correct?
Correct.
And so what does it do to the bone density? And you mentioned some of the long-term fertility issues, but what happens to the bone density? What happens to the brain? And we're talking about adolescents here, and to their fertility. If they never go on to get cross-sex hormones, what happens if they're just on puberty blockers?
So again, that's not data that's known in the healthy individuals who've chosen to do this to themselves, but we do have clinical cases where the puberty and inducing hormone GnRH is not present. Okay, that little baby boy I talked about would be somebody who would not experience puberty, and so those case reports, when the kids get older, when they get into young adulthood, they're at medical risk. When you don't produce testosterone or you don't produce estrogen, and testosterone is actually converted into estrogen for growth in boys, you do not collect calcium into your skeleton during the very informative time when you need to, which is the early teens up through age 25. After age 25, if you have not experienced puberty, your bones will then be a banking system that's depleted already with calcium. Calcium is an ion that is necessary for all the intracellular work in the body in the terms of muscles and heart muscles and many other systems. And so the bone the skeleton is a bank for that, from which patients will withdraw their whole life. If the bank has less deposit in it, by the time you get to your 50s and 60s, your body's going to take calcium out because you need to do that to survive. So what you're left with is very fragile bones and fractures that occur because of that, of osteoporosis. So nobody argues that. I mean, everybody on the transgender advocacy, quote, affirmation, unquote side says, yeah, we know that occurs, but they won't be alive to worry about osteoporosis because they're going to kill themselves if we don't do this. Okay. So it's like, it's a circular reasoning situation. It's just like, no, let's talk about the moment and what you're doing. The interesting thing is that there was a paper by one of the senior advocates for hormonal affirmation that said that fertility wasn't happening when you blocked puberty early on, and that unless you blocked puberty well into puberty, into the point where the gonads had developed enough spermatogonia, this was done in boys, fertility wasn't going to happen. And so they actually published the article looking at what boys wanted to preserve their sperm and then have them frozen and then go have their testicles taken out. And they were trying to prove that this was an avenue of success. And they came up with the fact that, we found out that unless a boy was way into puberty, typically 15 or 16 years of age, that they didn't have anything to freeze. So, what did that teach us? That taught us that blocking puberty up to the beginning ruins the production of the cells that need to be gathered and frozen for artificial insemination later on. And so unwittingly, they admitted that this is affecting fertility adversely.
Mm-hmm. And obviously, we know that the brain doesn't actually finish developing until age 25. So, what happens to the brain under the influence of these puberty blockers during the teenage years?
The evidence for this comes from England at the Tavistock Clinic, and by Dr. Michael Biggs looked at emotional wellness and mental health, use of antidepressant drugs, increasing in the population of kids that had blocked puberty. The inference there is something's gone wrong when you have a phenomenal mushrooming of the amount of mental health issues in patients who have had puberty blocked and were not allowed to go into natural puberty. And then the article on dementia, which was recently published, kind of looked at the other end and saying, wow, this hormone is so key and essential for development of brain structures that, we need to pay attention to that. And maybe that's a cure for dementia. I mean, that is, they didn't actually say it for the reasons that we find scientifically valid. They were just looking and discovering real stuff.
And so all of these things are the ethical red flags of why prescribing puberty blockers to children who are still developing is going to affect them in these ways, physically and emotionally, psychologically. What do you wish parents understood before agreeing to this kind of intervention for their children?
Well, first of all, that the benefits touted in terms of improvement in mental health are unequivocally false, and that actually there is ample proof to say that mental health actually deteriorates in the kids where you don't allow them to go through their natural puberty. It's not life-saving. That's what it's advertised as. It's a real straw man. It doesn't have any scientific validity. Nonetheless, it's restated and restated so many times in so many places that the lie becomes a truth. and that's a problem. Everywhere, if somebody just Googles puberty blockers, they're going to find 100 to 1 article saying this saves lives, this saves lives, this saves lives, and then there will be the stuff that's published that says this doesn't save lives and it actually causes problems. And so it's the volume and the sort of celebrity, if you will, of these things that makes parents go the wrong direction and make the wrong decision.
Mm-hmm. So let's move on to cross-sex hormones, giving estrogen to males and testosterone to females. What are the biggest medical risks you see when these are prescribed to children and adolescents?
First of all, they have side effects which are often really irreversible, but those are the side effects that the patient is striving for. So in a female who's given testosterone, it'll cause facial hair growth that can't be made to go away. It will enlarge the larynx and deepen the voice, and that can't be made to go away. But those are the things that they're aiming for. So it's like, well, that's not a side effect; that's the benefit. That's what I'm looking for. And in men, it'll cause the breasts to grow. And that's what they're looking for. And they'll, diminish muscle mass and make their body contours more fat over the hips, and so they're looking for that as well. So those are side effects that aren't reversible, but are the sort of the false idol that they're looking for. The undercurrent problems are the diseases that we've known about since we've known about hormones. Where healthy males who developed a disease state that overproduced estrogen cause them to have strokes because it increases clotting. And it also causes prostate cancer to increase. It also causes male breast cancer to increase. It worsens heart disease. And so those are disease states where the levels are not even maybe a third as high as they're pushing to artificially induce the changes in these kids on purpose. And so you say, well, we know about the disease states. We don't have to do a controlled study where we give these hormones and we wait 30, 40, and 50 years or 60 years to see what happens to their long-term health. That's unethical, and it's impossible by the time you get to the end of the study and say, oops, sorry, Charlie, you were part of the experiment and, you died of breast cancer or prostate cancer. And the same thing with the male hormones and raising testosterone to levels in females. Aside from the wanted side effects, there is an incredible increase in heart disease and cancers. And so it's like we know the answer. We've had it in front of us since we've been measuring hormones and looking at human physiology, even before we understood where these things happened or why they happened, we prevent them. Polycystic ovarian disease is a sort of a misdirection of the ovaries, where they start producing a lot of testosterone or testosterone-like hormones, precursors, and it causes now the women to have all sorts of health problems, and they're at risk for cancers in the uterus, and so we work aggressively to get those hormone levels back down because we know there's an ill effect. And again, the answer to that when that's brought up is, well, they're going to at least be alive, whereas these diseases might kill them. So, don't worry about that. Prolonging their life and fertility, because if we don't do this, they're going to kill themselves. And it's a ridiculous argument, but we know the harms. They're unequivocally, scientifically proven cases over and over again where the wrong hormones are in excess and disease occurs as a result of that.
It's, again, this is a case of you take a healthy person, a healthy body, and you actually make it sick by giving the cross-sex hormones. So this is not a healing act. This is not, I would say this is not medicine. When you're harming the body as opposed to helping it, then you're not participating in medicine. In your experience, what's driving the rush to medicalize these young patients rather than explore psychological support or the root cause?
The guidelines that have been published and touted as internationally accepted standards of care and adopted by major medical organizations most of whom are politically ideologically run. The ideologies tend to cloud the recommendations from the organizations. These organizations do a great deal of good as the core mission, but when ideologues get to kind of slip in and get in power and begin pushing agendas, the unsuspecting member of that particular medical society or organization assumes that this has been clearly scientifically validated, is unquestionably appropriate. They themselves are so busy in their clinical practice that they don't have time. A pediatrician doesn't have time to know all the stuff about hormones in these kids. They just say, hey, I'm busy taking care of kids and keeping them well when they're sick. It's out of my radar screen. I'm going to trust my organization to give me the information I need to know. And so that's how it has essentially just been stuck like gum on our shoe, if you will, where we can't scrape it off. It's very difficult to do that because these organizations are, we're thousands and thousands and thousands of members. People who don't want this are wild and crazy kooks who are on the fringe. Don't listen to them.
You mentioned before that the arguments that some people use is that, well, if we don't do this, then these children, these teens are going to commit suicide. And they also say that this reduces depression. How do you respond to those claims?
Well, first of all, I will tell you from my own clinical experience of evaluating kids who come to my office with an issue about their gender identity. First of all, it's a selective population because people will Google me and they'll say, well, if I want hormones for my child, I know I'm not going to get them there. So the people that come to my office are usually families that are wrestling with this. One parent doesn't want to do this. One parent is insistent on doing this. And so they come to me, the parent who wants to avoid harm, and I lay out all the facts that I have, and I direct them to websites that we've developed that say, this is the science, this is what you need to be thinking about in the long run. But that mantra of, it's improving mental health and it's preventing suicide is patently false. And we have all the data, published data to show the studies that are quoted. And I happened to listen in on a webinar given by a woman probably in her early 30s, who claimed proudly that her pronouns were she and her, and that she was a heterosexual white woman, and that she, this area is the newest of the new, and she had been working in this field for 2 whole years, so she had intense amounts of experience and knew exactly what she was talking about. And she gave a lecture, which was absolutely, and she brought up references. She says, I've got all these references. Now, at the end, I'm going to go ahead and let you have these references, but I'm just going to quote them because they're 20 out of 20 studies that I found said that mental health was improved and suicide was diminished. And then she just kind of went on to the next slide. Well, I could catch the titles of the authors, in tiny print. And they were the articles that are absolutely impossibly designed, taking convenience sampling from 25,000 mailed in or emailed in surveys, online surveys, where there was no verification of anything. There wasn't a personal interview. The mental health issues, it depended on whether the patient wanted to say that they were depressed at baseline, or it ignores it altogether. And so you've got studies that should never reach a journal. The quality is so poor. 20 years ago, they would have just been sent back to the author and say, I'm sorry, this is a convenient sample. We know we don't publish convenient sample and stuff. It has does not show causality at all. It might show some correlation, but that is not something that's based on good science. It's the lowest level. We're not going to publish it. Those things are now just in every journal. Month in and month out, you'll see things going back to the same the same transgender study, and they'll say 30,000, 50,000 people were surveyed, and this is all what they came up with. And that's what they rely on, and it is not valid, and it's not questioned. There is no time for questions with this presentation where I could say, hey, wait a minute, are you aware of the fact that this was convenient sampling and shouldn't be invalidated? They don't want that. So they lock the door. They give their speeches, and then close the door right behind them and disappear. And that's what we're up against.
Hmm. Well, have you seen cases of regret and detransition? And how do those stories affect the way you practice? And also, are there studies that show the effects of all of this, both mentally as well as do we have data on detransitioners?
So the detransitioners are out of my age range in terms of who I treat. So I have not had anybody. And first of all, I haven't transitioned anybody. So, but what I've come to know by just meeting the people who are detransitioners and listening to their very consistent stories. I mean, it is almost universal about their own internal awakening and their own shame for having done this to themselves, and how really difficult it is to unwind, and they never get back to where they were emotionally and mentally. They're better off because they have actually finally dealt with the undercurrent issues that made them believe they were born in the wrong body. And I will tell you that of all the kids, every single one of them that I have had come to my office with the complaint of being born in the wrong body, all of them had significant, unquestionable adverse childhood experiences that would just imbue them with anxiety and depression. And instead of dealing with that and getting the counseling they need, they end up persisting in this disbelief. So my treatment for the patients is never hormonal. It is always hooking them up with a valid mental health practitioner who has no agenda to change their mind, but to go in and work with the mental health issues that have been there and solve those. And I will tell you, that has worked in the patients that it's no question they have resolved their gender discordance and realized that they are born in the wrong body when they get counseling that is dealing entirely with the traumas that they have dealt with growing up, things that we don't necessarily think about. I was in the Navy for 20 years, and the families that were disrupted in terms of moved every 18 months because dad had to be on a promotion ladder to get where he needed to be. The families were uprooted and replanted, and uprooted and replanted. And sometimes at work, there's a kids that's just, they have a great life. They love it because they can clean the slate and get all new friends again. And they love living in different places. But that is a well-known adverse childhood event for most people. The death of a pet, the death of a sibling, the death of a parent or a grandparent or a best friend, the alcoholism of the parent, the drug abuse by the parent, incarceration of the parent, divorce profoundly affects the children. And so they're in the background. You just have to ask the questions and say, here on a list of things, have you experienced any of these things? And bing, 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 you've got 3 or 4. And then that's the root of the problem. Not that they're grabbing onto an answer and they're finding the answer on the internet saying, you're fine. The problem was you're born in the wrong body, and this is how we know, and we love you, and we accept you, and we cherish you, and this is the right place for you to be for the rest of your life. And the kid grasps that brass ring, thinking it's going to be okay. It's going to be get me out of my pain and agony.
And also, there may have been cases of sexual abuse or even autism, other conditions that they might be dealing with that are underlying
Correct.
what's causing the sexual identity disorder. If you could speak directly to medical boards and policymakers, what would your message be about puberty blockers and cross-sex hormones?
That we know that they're harmful when applied in the ranges we're talking about, that there is medical morbidity that is profound and irreversible in most cases. There is no benefit that can be proven in terms of mental health. The science is there. It's published. It exists. It's non-ideologically driven. It's based on very solid information, and it should be respected as such. And that we should have an open dialogue allowed so that we can state our case in front of our population of physicians and our specialists, and let them listen to the back and forth arguments that one side has and the other. That it would be it's like taking candy from a baby. And unfortunately, when we present the science and then they present what they believe proves their point, and you open up how their science was clouded by ideology, and that there isn't really proof, then everybody watching that would say, and that's not done in meanness. I mean, that I have no desire to make somebody feel badly. I want to just open the eyes of people. And in our medical community, that is not allowed to happen. Every time that we have suggested as members of our professional societies, let's have an open dialogue. Let's have a tit for tat session. He said, the old thing that used to be on Saturday Night Live, where they would have, opposing opinions, and they would call each other names. But I mean, the idea would be not to name call, but just to say, there are people who are, sound and scientifically grounded, who have reached a vastly different conclusion. And there's a reason for that we would like people to listen to. And if we have criticism of how we have presented stuff, we're open to criticism. It's not a problem, but just don't put yourself behind a wall and lob nasty things over the wall and close the door and not discuss things. So an open dialogue has been denied over and over and over again.
Mm-hmm. Well, I think that history will kind of play itself out, right? And all the people who have gotten these puberty blockers, cross-sex hormones, we will see the effects of them. Some immediate effects, obviously, but also the long-term effects over decades. And so hopefully that will change the way that healthcare professionals are looking at this, even if right now they don't want to listen, right?
Yeah, but the sadness I experience thinking of it that way is that in the meantime, we're going to have tens of thousands of kids who were profoundly adversely affected, and the states are individually looking at ways to increase the statute of limitations to 25 or 30 years, or maybe even 50 years. So when the regret happens, the physicians or organizations that led them astray will be held financially accountable for the morbidity that has occurred as a result of that. Mm-hmm. That's one way to do it. And it's interesting because for any other issue, the people on the other side would say, oh, yes, that's a great thing. We want to hold people who do very bad things accountable forever, except us, because we're doing good stuff and we don't want to be held accountable. So it's an argument of like on parents' rights. Parents have the right to do what their children, and doctors should not. Governments should not get in the way of what the parents' rights are. Only for the issue of transgender. If they want to teach human sexuality in the classroom, we can do it without the parents' consent. So it's just like you can't be pro-life and not be against euthanasia and the death penalty. I mean, it's pure. The ideology is there. You stick to it, and you can't cafeteria-ize and choose. This is what I like. This is what I don't like.
Right. And, obviously this is why we're doing these episodes, because we want people to understand all the implications and hopefully help policymakers, but also help their family members. Maybe they have friends or family who are considering these types of interventions, and it could help save them from the harm, both the physical and emotional, psychological harms of these. I want to go back to John Money. We mentioned that we were going to discuss him for a little bit, and thank you for the introduction to him. Could you talk a little bit more about what his core message, maybe even his core theory was, and how did it differ from what endocrinologists and psychologists believed before him?
The whole concept of human sexuality was has been in the background like late 18th century, and of course I think in outside of the medical profession, people had their ideas of what happened with hormones and how you grew up and who you thought you were and who you were sexually attracted to, and the events in your life, your mechanical expression of your sexual desires. That's always been around, and in our church would teach us very specifically there is a reason, and it is for procreation, and this is how God increases the humanity on earth, and it needs to be treated with the utmost respect within the confines of a moral compass. So when the moral compass just sort of isn't present, or is sort of thrown aside, then individuals like John Money and the Frankfurt School back in the late 1800s come up with, wacky ideas about, well, we think this is where this comes from. And, it's not wrong. That's judgmental to say it's wrong. So let's try to normalize everything we can that had previously been called perverse. And so that was the role of Kinsey, is that he very falsely gathered data to say that this is the norm. And that was published in the 40s and 50s, and first for men and then for women. And when you go back historically, as Judith Reisman had done, to tease out how these conclusions were done, what the surveys were, you realize it was driven by an ideology of saying, you're the center of your universe. Don't let anybody tell you if something's right or wrong. And so that was coming to fruition. Endocrinologists otherwise were all just into the hormone actions, the disease states. Sex was sort of over there. We didn't really like to talk about it. We knew that adult males who had absent testicles had a problem with libido. We knew that women who had excessive adrenal hormones that were in the same class as testosterone tended to be more libido driven than their non-hormonally abnormal peers. So we sort of knew hormones created sexual drives. But it was kind of separate and not really looked at as a mainstream kind of concept. And then the 50s and 60s and 70s came along with the sexual revolution, and all of a sudden it was, hey, let's open the door and try some things. And that was John Money's thing. I alluded to it before. He said, I have an idea. Let's see. If we do this to this kid, I'm assuming the following things are going to happen. So I'm going to do it to some other kids and see if my idea is right. Now, this is pre-informed consent, protection of human subjects, no research protocols, just open-ended. Let's give it a try. When Money was at Hopkins and dealing with babies who had genitalia that were malformed, he would say, oh, this one is going to be raised as a girl. Oh, this one's going to be raised as a boy. Let's go ahead and get the surgeons to modify what's there so it looks like the direction we're going to push them. Let's create an artificial vagina in a little boy whose penis was burnt off. And let's go ahead and raise that one as a girl. We're going to go ahead and have this boy and his artificial girl and his twin brother be naked together and stimulate each other as young children. And we're going to make sure that they kind of grow up and get into their sexuality in the direction we think it should go. Now, that particular case, the Raymond twins, had been published by Money before I was there as a fellow. He was writing up the case and had written several books on gender identity and how malleable it was. And what we didn't know, we didn't take care of those kids. Those kids were in his purview. The endocrine division the pediatric endocrine division had no idea what was going on with them. The parents described what they had seen physically. We were unaware of that. We were aware that Dr. Money had perverted ideas. Okay. I came to my fellowship I was on active duty in the Navy, and in my residency program, our floor in the hospital for pediatrics was shared by the orthopedics division that did prosthetic limbs for people coming back from the Vietnam theater who had their limbs destroyed. And they had a beautiful program where they developed for technology at that time, artificial arms and legs and whatnot. They had a team of mental health providers that dealt with these young men coming back about their missing extremities and about their body image and about their sexuality. And so they paid attention to all those details and cataloged them and looked over. They wanted all benefit and the best of circumstances. So I knew that this kind of stuff went on, and I actually interacted with a number of the amputees who would be in their wheelchairs coming down to say hi to the kids on our side of the building. I imagined what a trauma it would be to lose an arm or a leg. And how that would affect your life. And so we would get into some conversations about how they were feeling, and all that was being beautifully dealt with by the professional staff. So fast forward, I'm in my fellowship at Hopkins, and John Money comes in with just a pad, like a legal pad and a pencil. And this wasn't a PowerPoint. We didn't have PowerPoint presentations back then. And he started drawing with his pencil, and he drew a leg stump. And out of the end of the leg stump, he placed a little hole that simulated the opening of the urethra on the human penis. And he had depiction of squirting semen coming out of the end of that stump. And he said, I have a theory that people who have amputations really do this to themselves on purpose because they want to have a stump, and that they are sexually attracted to the stump, and they want to masturbate with the stump to climax. And I just opened my mouth and said, well, Dr. Money, I was in touch with a number of amputee patients who were at the Naval Hospital in Oakland. That were our neighbors on the floor. And that was never a subject that was ever talked about. And they thoroughly evaluated the mental health of these kids. He said, oh, well, never mind. Closed his thing and said, we're done with our lecture today. And that at that moment, I said, I'm not listening to this man. I mean, he is perverted. He purposely made really crass remarks, sexually innuendo remarks to the religious female. We had two Catholic fellows that were a year ahead of me, one from Iran and one from Poland, who defected with her mom. And he would specifically direct comments to them to make them feel uncomfortable and to ridicule their faith. And so I thought, this is a disturbed man. I'm not a psychologist. I'm not going to say he has, but his concepts to me seemed very perverted. And so I just kind of wrote him off and did as little as I could to have to be in front of him or listen to him talk. So, and then that last case that I previously said was sort of the icing on the cake. He looked like a train wreck. He would come in, he looked like he'd kind of slept on a park bench and had a binge the night before, saggy clothes, oily hair. He took a break and came back with a curly perm. And that was the sort of the new persona, same crazy guy inside. And I just thought, why is Hopkins putting up with this? I don't get it. And then Paul McHugh took care of the rest.
Mm-hmm. Yeah, I mean, it's very disturbing to hear some of these stories you have of him. And of course, you mentioned the Reamer case. These were twins. Can you walk us through what happened in that case, and also about what happened during the quote unquote therapy sessions that Money had with the twins? You're saying that he's a disturbed man, and obviously during the therapy sessions there were some huge ethical violations, acts that would be considered child abuse today. Could you tell us more about this case and what happened?
So the Raymer twins were born, and a circumcision was done on both of them. And on the one boy, the surgeon who did the circumcision used an electronic cautery device called a Bowie knife. And the Bowie knife is used for cautery. A little bit of electricity is placed on a bleeding point, and it causes clotting, and it allows that. It sort of cauterizes the tissue so that bleeding will not continue. Bowie knife has two settings: one for cautery and one for cutting. And the cutting is vastly more powerful setting. Yeah. And this was set not on cautery, but on cutting. And he literally sliced the boy's penis off as a result of that. Kind of a oops moment. And then, the child was then sent to Hopkins because John Money was there, and he was in the business of reassigning sex on babies. That was his reputation at the time. And his recommendation was remove as much of the remaining stump of the penis as you can. We're going to have the GYN surgeons who are very adept at adult surgery, who've been training now in microsurgery for kids. We're going to create a vaginal opening for this child. This child will be raised as a female because that child will never function, in John Money's word, never function as a male. And so they were raised as such, male and female twin. The babies were unaware of this. They weren't told this. They were told to keep this a secret. They were in the counseling of the Money group. That's all. They never went outside of that. until the boy that was being raised as a girl got to be in the middle school years and began having profound issues with depression, and he did not want to go back to money. The story in between, you can tell why. He was then, it was disclosed to him when he was a young teenager that he was actually biologically a boy, and he said, I've just known this. I've just known this. I mean, I was hurt. This ruined me. They reconstructed some of the phallic tissue into a stump that was potentially somewhat useful for intercourse, but not really. And of course, his testicles had been taken out, so he was infertile. He went through his teenage years. He married. He adopted children, and in his mid-20s, hung himself from a swing set in the backyard. His brother, who obviously was traumatized early on by the stories of the parents told, was drug addicted and essentially committed suicide by drug overdosing. When that story, the final story of their deaths came out, there was a retrospective review of what had gone on. Now, the psychohormonal group, which was what John Money created, kept interview notes. They recorded absolutely everything that was said, and it was transcribed and typed on what we called then onion skin paper, very thin paper in with copies. And a copy would be placed in the endocrine chart. Money had the original, and it described every single thing that was said. It was just unabashed, wide open. We found out that with some of our kids, one boy who had a testicular tumor, and he was 6 years old and had adult-sized genitalia, who would come in to the walk-in clinic for a school physical, and grandma brought him, and they called him man because he had the stuff. He ended up having this testicular tumor, which was taken out, and it resolved the problem. But he was interviewed by Money serially on occasions, and at one of the first interviews, and I read through this with horror, Money asked him, "How often are you masturbating?" And this kid who was 7 or 8 didn't understand what masturbation was. So John Money took out a pencil and stroked it up and down and said, "This is what masturbation is." And so at the next interview, when he asked about masturbation, the kid was masturbating 5 or 6 times a day. So that was just black and white in transcript that we saw that. And that, again, was one of the many things that said to us, this is a perverted man. The Reamer story about what happened in the confines of his office is what was told by the parents to a man who wrote a book about it called As God Made Him. And they described the fact that both of their children, the boys, were stripped down naked and made to in the office on the floor try to have simulate intercourse, and that parents were told to take the boy who had this artificially created vagina and constantly stretch it and stimulate it, and have the sibling do that with their fingers. This is stuff that is, there would have been an orange jumpsuit and Money would have been buried forever.
Horrific.
But this book described the parents actually having been in the sessions and watching this happen. That was nothing I knew about. I mean, that was all behind the curtains, and I was completely unaware of it. If I'd known that, I might have been compelled to call Child Protective Services. But, that was kept out of our purview. So that is just, that was the thing that broke the camel's back in terms of getting Money to be dethroned as an expert. And he was. Hopkins was so embarrassed about what he had done, they stopped all publication of his books that he'd written. And then in 2017, when Hopkins opened its transgender clinic, they brought him up gloriously from the cellars and put his name back on a pedestal, saying he was the grandfather of transgender health. And they are so proud to have been at the onset of this whole movement all along. And this was an article written in their Children's Hospital magazine. And I wrote a letter to the editor and said, how can you possibly celebrate this man? Are you not aware of the history? The letter was never published, and I never heard anything back.
Oh, that's awful. Why has, obviously after the Reamer twins case, that was used to propel the gender ideology narrative theories. why was that never reversed once the truth came out about John Money and his very unethical and perverse experiments on children?
Well, it's kind of crazy because in part that's used to show that gender identity is innate. Okay, I mean this is crazy, but you see, the boy was always a boy because his gender identity was a boy, and that's biologic. And so when Money tried to change that, it didn't work. You see, it just proves our point that gender identity is biologically determined, not socially determined, not there is. And so they took that awful
Mhm.
story and awful circumstances and said, you know, it proves to us. You see, there you go. And you look back and say, no, it doesn't prove it's biologically innate. It proves that a boy knows is a boy, and the cells of the body know, and the brain knows, and you can't make that. It doesn't work to try to switch it. To try to switch it just makes mental health go to hell in a handbag.
Mhm. It sounds like John Money followed very closely in the footsteps of Kinsey, Alfred Kinsey. Did Kinsey also have some awful experiments because he came before John Money? Do you know if John Money was influenced by him? And what can you say about the experiments that Kinsey did on children?
Money spoke of Kinsey, and I think they did know each other personally. I mean, they were sort of in a field of very, very narrow expertise, quote unquote. The experiments that Kinsey did with children, um, and it was referred to as displayed in Table 34, quote unquote, in Judith Reisman's. And I was imagining there were a room full of tables. And there was one over here, which was table 30, like with a little, little cone on it. So this is table 34. What table 34 it was a description of how many times infants and toddler boys could be masturbated to the point of ejaculation or
Wow.
climax. And I mean, that just blows me out of the water that there would be anybody allowed to do that.
Mhm.
And it's in the book. It's in his writings, and the Kinsey Institute, and they are proud of that at the Kinsey Institute to this very day. That say, the sexuality is there in infants and toddlers, and we can prove it because we masturbated these boys. And it was just amazing how many times we could get them to come to a climax.
Mm. That's just so
Yeah,
awful, and
it's just,
both of them,
yeah.
just, horrific, and hopefully this brings attention to, uh, their experiments, their extremely unethical experiments on children and their abuse of children. So obviously their experiments, even though they had catastrophic results, did both of the Reamer twins commit suicide or just the
Well,
one?
one actually hung himself, or there are two things. He either blew his head off with a shotgun or hung himself in the backyard. One of the two, and then that was the one that was trying to be raised as a girl for a time. The other one just was a drug addict and overdosed.
Mhm, mhm. So why do you think that the medical community was so ready to accept his theories at that time?
They weren't. When I actually went, because I trained at Hopkins and I had applied, the Navy allowed me to apply to everywhere I wanted to as a fully funded fellow. So for the universities, I was a fellow, but I didn't cost them a dime. The Navy actually paid them for me to go. And so I applied to 5 programs and got in all 5. And one of them was University of California, San Francisco, where I'd had a lot of experience going to grand rounds and they're teaching things because I trained in Oakland right across the bay. And they had an excellent program in endocrinology. It was profoundly emotionally traumatizing within the walls of that fellowship. And I didn't want to have to experience that, even though I knew the faculty was just, incredible. Hopkins had a much broader faculty, had faculty that were kind and thoughtful and beautiful mentors. So I chose the one I wanted to go to. Because I did not go to UC San Francisco, when I came back after my fellowship and I was back in the Navy, back in the Bay Area again, running the residency program at Oakland, I would take my residents over to the UCSF program for the morning rounds and stuff. And one of the faculty members would just chide me and saying, you know, you went to Hopkins. They had money. They had John Money. Aren't you embarrassed to say that you went to Johns Hopkins? It was an embarrassment. I mean, in the endocrine world, the adult endocrine world, and completely shunned all of this for the most part, and nobody in pediatric endocrinology was doing anything like this at the time. So I was sort of ridiculed for having gone to Hopkins, where John Money had played forth and made a fool of himself and a fool of the world. So that how that all of a sudden turned right around was the infusion of the transgender issues from the Netherlands through Dr. Norman Spack in Boston, and then there were select places, Chicago, Los Angeles, where agenda ideologically driven pediatric endocrinologists planted the seeds and very cleverly got into positions of power where they could create these clinics, and then spun their web of deceit about how this was all scientifically based.
Hmm. I mean, it actually seems that his unethical experiment disproved exactly what he was trying to prove, which was that sexual identity is not just a learned thing; that it is innate. That's in our body. It's in every cell, right? Our sexual identity, every cell is sexed, right? It's male or
Yeah,
female.
it's actually, I would say, instead of an identity, it's a sexual direction. Okay, it's a sexual being of the cells. The identity thing is where we get into trouble, because the concept of using the word gender instead of sex is because you don't have to say the word sex. When you mean sex, you don't have to say it, because that's an act. Okay, it has a connotation that we can't talk about that in public. Whereas you can mention the word gender till the cows come home, and it doesn't bring up any thought of intercourse or any kind of activity or attraction. The gender identity issue was sort of promoted by John Money as to saying that is an innate thing. And he accidentally sort of proved that the gender identity it comes from, you can't mess with it, because if you try to do it with social circumstances, you're going to create mental health issues. Okay,
Mhm.
so looking for a marker of gender identity is interesting, because there is none. If a patient comes in unconscious to the emergency room, appearing to be a man, and ends up being biologically a woman, there's not a blood test that says, oh, well, I guess if we get a chromosome analysis, we could see XX versus XY in most cases. But what's the gender identity? Where does that come from, to allow you to treat people according to a biologic marker, which would then say this is innate, it has a civil right to it, much like race and whatnot, that this is not just a belief system. This is something that is inherent in the body, and we can measure it and find it. Well, you can't measure it and find it, because this just doesn't exist. It's a thought process. It's a social construct.
Right. And again, the word gender actually comes from what, in some languages, things are gendered, like a chair or a book, etc. It's an idea that is not actually, it was not meant to refer to people's identity, because we are either male or female, and biologically speaking. So gender itself as a concept, we should do away with completely, because it's not biologically based, as you mentioned. It's actually, what he did was make a philosophical leap or theoretical leap. It wasn't practicing actual medicine or science, right?
Correct.
So, and that's the thing. He was largely, some people think of him as a scientist, but his ideas were theoretical. What is the biggest thing that is misunderstood about his legacy?
I think the bringing him up as a hero when they opened the transgender clinic is the idea that he was a pioneer. That he broke the glass ceiling of stuffy, you know, uh, religious based, ethical, moral compasses. That's not what should rule the world. That you can have a freedom to be who you want to be and do what you want to do. You have the personal freedoms to say, I can do anything I want to anybody that I want to in terms of sexuality. And so that's kind of for someone who's growing up through adolescence, even in today's age, that's kind of like, whoa, I like that, because my parents have drilled into me this sense of ethical, moral compass in terms of my sexual behavior. I remember that lecture from my dad. It was, if you get a girl pregnant, and you're going to pay for college, and you're going to get your own job, and you're going to live on your own. We cannot support you financially at that point in time. That made a lot of sense to me. That was, aside from the fact that at that particular time I wasn't profoundly into a faith lifestyle, but it made really good sense. There is a reason not to just be sexually willy-nilly. You focus, you take care of yourself, you use a moral compass to guide your life. And in those adolescent years, it just inherently, it's like banging against a wall. You give me walls, I'm gonna go up against them, Dad. I'm gonna show you I'm smarter than you. I know more than you. We've all done that. That's how we grew up. And what you realized is that those walls had a very good purpose. That they were built because your parents went through the same agony and angst in adolescence, and things far worse, the Depression and World War II or World War I, and they came out, strong and with values. And so it's like, okay, I guess I'm okay. I can question everything, but the walls are the walls, and they have a purpose and a meaning. So there you go.
Having guardrails, right?
Yes.
So this kind of defeats the theory that we're all just a blank slate, right? That you can just impose whatever ideology on us, because biologically our bodies are already telling us who we are, right? But looking back, what do you think that John Money's story teaches us about the dangers of ideology driving medicine?
Clearly that so much harm was done, okay, of all the kids, all the infants that we knew where genital surgery had been done to try to change the biologic sex and appearance, none of it worked. Those kids came back to being who they really were biologically. Our job as physicians is to do no harm. And so that's the core of our medical practice, what we swore to and we graduated from medical school. The lesson is that when you step outside of a moral and ethical behavior, you will do harm, and intended or not, there is a reason for a code of ethics, and you want to call it being judgmental. Go ahead and do that. Being judgmental is not a flaw. It's looking at the world around you, looking at your faith beliefs and incorporating in that and saying, I can say this is right. I can say this is wrong, and not to be afraid of saying, well, we'll put it in a gray zone. That's my opinion. You have your opinion. Let's meet in a gray zone in the middle. And then all sorts of havoc happens as a result.
Do you see traces of Money's ideology in how today's gender clinics or medical associations approach chemical and surgical interventions on children with sexual identity disorder?
People don't often quote Money anymore. There's so much new ideology that's layered over the top that I think they know that's a lightning rod for people to discover what really went on and what kind of person he was. So aside from that, bringing him up at Hopkins and saying he was a wonderful person and a pioneer, I don't see that being said at any of the other medical centers that have done this, and in lecture halls. I attended a school board hearing in the neighboring county here, where a transgender pastor talked about the wonderful things that John Money did, and the whole idea of history shows, humanity shows that there's always been these individuals in various cultures who are the two-spirit and whatnot, all this stuff that brought up John Money. But that's the only time I can really recall anybody going back to Money and using him as a reference.
Mm-hmm. Would you call our modern day interventions experimental medicine?
Absolutely. There's no question it is not controlled. It's not consented appropriately. The consent forms are written, they're checked off, but the people who have done that freely admit all they wanted to do was to get their hormones, and they had to do the check marks. They had to check here, check here, check here, check or sign here, with the pressure that if they don't do that, they're going to die.
How should the medical field be handling this ethically?
They should open it up. They should open up the whole issue in front of everybody. They should listen to us. They should listen to, to the other side. We should be able to compare notes. We should be able to express our concerns without being thrown away as, unimportant non-scientists from the fringe. The medical community deserves to treat us better. The medical boards need to listen to us. They need to get out of the politically driven things that said that we're doing this because it's a LGBT issue and LGBT rights, and it's a suppressed, maltreated population of individuals. We do not want to be part of anything that smacks of judgment and condemnation of the LGBT lifestyles.
Hmm. I want to pivot to looking into the future and just trying to leave a hopeful message for people. I know that some of these things that we discussed are very difficult, very dark. How do you approach conversations with parents who come to you confused or frightened about their child's sexual identity and who are trying to navigate this issue with their child?
The first thing I do is I introduce myself to them, and I introduce myself to the child in question in front of the parents, and I ask permission from everyone to talk to them individually if they that I would like to kind of listen to what they have to say. But that first and foremost, the patient is my client. I am their advocate, and it's going to be potentially rough, but I will withhold no information from them on the subject. That I know an incredible amount of stuff that has been discovered, that has been found over time, and that my job is to be sure that they do not come to harm. And I tell the parents, both parents, you need to love your child. Your child needs to understand they are loved. I said, I care deeply for your child. And I actually, one of the most amazing moments was a 17-year-old we had about 5 sessions before our last one. And each time the other sessions, she was screaming and writhing and saying she was going to kill herself if she didn't get her testosterone shots and on. And I would just sit calmly there and listen to her. And I would say, I want to give you some more information. I want you to understand that, this is where I'm coming from the science. I have your best interest in mind, and I really do deeply care for you. And in the last session, she said, how can you deeply care for me? You've only seen me 5 times. And I just grabbed her hands and I said, I can't bear to hurt you.
Hmm.
And it was kind of an almost tearful moment. And she looked at me and she said, do you mean I can't become a boy? And I said, yeah, that's what I've been trying to tell you. And she said, well, then I don't care about hormones anymore. I'm done. And either she was twisting my leg and I'm a fool, but that was one of these moments where I said, God had stepped in. The Holy Spirit was behind me doing the right thing.
Beautiful. Are there other stories like that where kids saw you when they were teens and then came back as adults saying, thank you for not letting me go through something like that. Thank you for protecting me from harm.
My most recent patient that I had seen from age 8 or 9 as now finishing high school and is going to go off to the working world, which is a time where I say I part with those patients. I keep kids in my practice until they graduate from their first undergraduate program, if they're willing to stay, because that's a great time in life. And I love to hear what's going on. And I would like to know where they're going to go, what they're going to do, if they've fallen in love, if they, this is the closure that I need to kind of put them, and to send them on into the adult world. And so I said, are you going to be going to school? She said, no, I'm going to be working for a while. She said, I'm going to figure out what I want to do, but I'm now going to be working full time. And I said, well, I really have enjoyed working with you. And I know now, because you're telling me, and your mom who's sitting here is telling me, that you've accepted who you are in terms of your biology. I suspect that she's probably same-sex attracted, but that's not an issue I'm going to deal with or going to even bring up at this point in time in her life, because she is at peace. Her counselors are working with her. They say she is far happier than she's ever been at any point in time in her life. She had a bunch of trauma, divorce, accidental genital burns when she was 3 years old, and burn therapy, plastic surgery in the genitalia that was painful for the treatments and the follow-up. And I gave her a big hug, and we just sat there, hugged, said, "It's great. You're going to be okay." And she says, "I am okay." So
Beautiful. What keeps you hopeful despite the cultural and professional backlash you faced?
good people are listening. The organizations that I am a member of are flourishing, being recognized as experts in the field. I feel respected for my viewpoints. I have a Friday morning men's faith group called That Man Is You, and everybody at the table, 8 or 10 of us, know what I am up to in terms of the what's going on in this transgender world, and they give me encouragement at every meeting. Say, go out there and do the right thing. We're so proud of you. So I get the sense that there is in the population in our country a sense that this is all wrong, and that we're now allowed to question it without being lambasted as racists and bigots and terrible people. And the more that happens, I think the walls will continue to crumble and the truth will be out.
Mhm. What role do you think parents, doctors, and ethical medical organizations can play in restoring sanity to pediatric medicine, especially on this issue?
We just need to advocate with kindness and not malice. We have to refrain from the things that we may just really, really want to say to people or about people who are on the quote affirmation unquote side, so that we don't come across as we feel they are, which are just name calling and screaming, protesting, threatening, things like that. If we play the upper hand and play out our faith in our lives and our ethical precepts in our lives and live our lives that way, by example, I think we will just inherently gather more people to open their eyes. But I think we also have to be unafraid of taking every opportunity we are given to make our point, to show the love and care that we have for these children, that we are not anti-trans. We are pro-kid, pro-health. That's our role as to heal and do no harm.
Mhm. And for young doctors who are quietly questioning what they're seeing, what advice would you give them? And what core principles would you tell them to hold on to in an era where medicine and ideology often collide?
I would have them look into the organizations that are aimed specifically at them as students. The religious-based medical associations, reach out to them, give them a helping hand to keep their faith, to network with each other within their medical schools and their residencies. Those organizations and those outside of a faith-based organization like the American College of Pediatricians, like Do No Harm, like the Alliance for Hippocratic Medicine, they set up opportunities to find the students, invite them in, and give them the resources that they need to be strong and to recruit their fellow students into the ideology, out of the ideology world into the science world and ethical kinds of means of practice for their future.
Mhm. And probably also not to be afraid, right? You told a
Absolutely.
story at the beginning of your mentor, right?
Yes.
Your ex mentor,
Yeah.
telling you to not open your mouth about what's going on. But I think that we need more people, and especially from the medical community, to call it out for what it is. But not just in the medical community. We fully encourage all the listeners to also call it out, because the more that we all talk about this and about the dangers, then the truth will come out that science is on our side, biology is on our side, that this is something that is harming people and we need to stand up for them, right?
I'm just thinking that, the things that people who are not themselves physicians, but who are advocates for us on this side of the issue can find places to join and lend their voice and their personal support, their encouragement, their financial support, like the American College of Pediatricians, like the Alliance for Hippocratic Medicine. Those organizations are designed to do the work. And if you can't be somebody who's actually a physician, you don't have to be. You can be a worker bee and a volunteer and a supporter to let us do what we can do with the resources we have, expand our message, make it essentially to be the common opinion of the day, as opposed to being pushed into a corner.
And we will certainly link to those resources on the episode page. Looking back, what do you think the next generation will say about how medicine handled this moment?
I think it will be similar to the frontal lobotomy tragedies that happened, and to things like the Tuskegee experiment, where human subjects were treated just like animals with no ethical means, but just to kind of, I have an answer I need to get, so we're going to do this to some people, wittingly or unwittingly. And I think this will be a chapter in the future where we'll look back and say, what were they thinking to even begin to go down this road? And that's my dream, is that it will be something that they say we need to be on the watch so we don't fall down one of these rabbit holes unwittingly in the future. So,
And finally, as a pediatric endocrinologist and as a man of science, what do you think true compassion looks like in treating kids with distress over their sexual identity?
compassion is to let them know how deeply you care for them, and that your intentions are focused on what is scientifically valid, not driven by an ideology, not even necessarily driven by a religious conviction, okay? Because that sometimes is offensive if your religious convictions are a different one than the patient happens to have. To just get to as pure as you can be and look into them and let them look into you and see each other's heart, and just say, my job is to heal. And that's what I live for every day.
Well, we're so grateful for all that you do, Dr. Van Meter, for children and also to bring up the harms of the gender ideology. And we thank you so much.
Glad to be of help. Look forward to talking again soon, Arena.
Thanks so much for listening to this episode of the Bioethics Babe podcast. If you've enjoyed this content, please subscribe to my YouTube channel and your favorite podcast platform, and share with your friends and family. Also check out bioethicsbabe.com for the latest episodes and resources.